ready for CCO Club webinar number 72. Have a question that came in from one of our club members. I had to go do some research. I was not on top of this particular question, so I appreciate that coming in. I learned a lot doing the reviews. If you want to ask a question and be a part of our club at cco.us/club, today we're going to be talking about coding adaptive behavior treatment. The codes that we're looking at are CPT codes 97153 through 97158. There are some other codes that we're going to mention that fall around the same category. However, this is really the range that she was asking about, and the resource at the end of the slide, that resource slide, two excellent resources. One I was able to get from another presentation that was done for providers, and I think it would be a good idea for you to go jump out and look at that, because there's even more content regarding billing some of these codes. The questions that come in from our CCO Club members always get priority, and eventually they're turned into CEUs. We not only do things like the webinar support and stuff, but our club members get all of our presentations that maybe you're seeing if you're not a club member, because we live stream a lot of this content. The club members, though, because they're exclusive, they get the transcript and the slide deck. And tonight, the slide deck's pretty meaty with content. We do both billing, coding questions across the gambit. I'm really hankering to do some of our pearls that we did. And I know Claire might be on tonight, and she's going to be helping with that. So a little shout out to Claire if you're on already. Extended product support. A lot of our club members are our students, or they've purchased other items from us. We don't do only one credential. We work lots of credentials that we help you with, from compliance to pharmacology, inpatient, outpatient, and specialty like CRC and stuff, the risk adjustment. Again, if you want more information about the CCO Club, really easy to find. It's cco.us/club. Excuse me as I trip over my tongue. Adaptive behavior, that's what the question was. And I'm going to read it for you. It says, I would like to know what is required on the documentation that will support this service, or how to differentiate from the psych or behavioral health services. Also, what would support protocol modifications? And when I first looked at this, I thought, oh no, I have no idea. And it is an area that not only has a specialty that you can get a credential in, but it's an area where they're really seeking education. Things have changed in the last 5 years, maybe even 3 years, I would say, pretty radically. One of those reasons that because of the changes is that payers are actually reimbursing for behavioral health. And we didn't have that prior to 2016, I believe it was. You had to either pay quite a bit extra for it, or it wasn't part of your plan. It wasn't an option. But because of the attention that behavioral health has gotten in the last decade, it's really made a change, as well as the codes that you've coded that has shown what types of ICD diagnoses and treatments have been beneficial. So there has been improvement due to behavioral health. Therefore, statistically, we've seen the significant changes that it can make. Thus, let's get it paid for. The person who asked this, really excited that you did, because again, I was able to get some research and find some information that I was not aware of. First thing is I wanted to kind of give you a definition. What is adaptive behavioral services. And there is several types of words and verbiage that are completely different when you look at it from the medical standpoint, whereas like a clinician in a hospital or outpatient setting would look at it, versus behavioral health or psychology. Very, very different. And so if this is something that you're interested in, I think you want to look into that. When you go in and look at word meanings, the root words tend to be the same, however, some things like adaptive behavior, it's not something that you hear in the routine office visit. So it is a specialty. Going on with the definition, it's going to be services that address deficient adaptive behaviors. Thus, we're talking about following instructions, verbal and nonverbal communication, imitation, play and leisure, social interactions, self-care, daily living, personal safety skills, or maladaptive behaviors such as repetitive and stereotypic behaviors and behaviors that risk physical harm to a patient, others, and or property. Now, if you don't look at the brackets there, you take those out, then it's going to read, adaptive behaviors, and then it says, or maladaptive behaviors. When you first read that, you think, oh, maladaptive behaviors. So that means people that cause problems, that act up or are just, bad behaviors, right? That's what mal means, bad. However, let's look at the definition a little more closely in the examples. When we see deficient adaptive behaviors, if you have a person that isn't able to communicate verbally, they don't have strong verbal skills due to maybe mental IQ, then this would be adaptive behavior for them to become more articulate, to be able to express themselves and not be frustrated, find out what words will allow you to get attention to what you need versus having an outburst. Or again, maladaptive behavior, repetitive. If you have a person that is a patient who's had any type of brain trauma, any kind of brain injury, and this could even be strokes, but we're talking, trauma to the brain. So one of the things that's noticed is that they get repetitive behaviors and they get repetitive speech. So, I'm always using family members as examples. I do have a son that has brain injuries in his head due to probably birth, but he's had it since birth, and he has epilepsy and he's autistic. Now, some people don't like to talk about autistic spectrums and so on and so forth, but we'll just say what his limitations are. He can interact with people, but he doesn't know social norms. So what would that be? Maladaptive behavior. If a person were to get up in your personal space when you talk to them, that's not normal, right? So we want to teach them that's we need to adapt their behavior to let them see how that makes people uncomfortable. So what would you do instead? And then you practice that. Other things, the repetitive, he's very repetitive in not so much as like repeating a word over and over and over again, although he has done that. It's like a train of thought he can't get out of his head. So he'll ask the same question over and over again. He may tweak the way he asks it, but it's the same thing over and over and over again. So we, teach him to recognize that he's doing that, because ultimately, what does that do? Well, it defeats the purpose, because people get annoyed and they're not going to answer your question. They just want you to go away. And meaning I'm talking about his siblings and stuff. So how better what's the adaptive behavior in those situations? Well, one is that you answer his question right away, or you figure out a way to change his motivation and his focus until you're able to answer the question for him. And that's just little things, as well as notice, that verbal and nonverbal communication, imitation of play and leisure social interactions, self-care, and daily living. So daily living, he can't cook for himself. He wanted to learn how to cook an egg, and we'll stand over the stove and we'll cook an egg together, but he'll never be able to do that by himself because he won't turn off the stove, and so daily living practice. Now, if there's somebody that could he eventually do that? Maybe, if it's repetitious and stuff, or if there's somebody there saying, don't forget to turn off the stove. Okay, he knows how to turn off the stove. It's just he wouldn't remember to do that. And take his medication, things like that. So again, there is a reason for adaptive behavior. Adaptive behavior doesn't mean you're a bad person and you need to change what you do. It means we're going to adapt your behavior because, one, it's not within the norms, but even if it's not within the norms, it's not healthy for you for whatever reasons. Very good. All right, moving on. The CPT codes that we're going to look at that's in that code range, I went ahead and kind of did the BAT technique with these codes, although it really isn't set up for the BAT technique in that, yes, you could bubble these codes into one bubble, so I would suggest you do that. However, there's no semicolon, meaning there's a description and a semicolon and then the rest of the information. These particular codes are a little different, but this is what I would bubble and highlight with and underline. These are what I would want to pop. So again, you can copy this. If you have your manual out, you can do that while we're talking. And of course, if you're in the CCO Club, you're going to get the slide deck so you can go back and do it on your own. The first code is 97153, and that is adaptive behavior. Now, I'm not going to read all of these after we get going, but I'm going to read this one to you. So adaptive behavior treatment by protocol, meaning there's a plan in place. This is what we've established. Administered by technician, right? So it doesn't have to be the provider. It can be a technician under the direction of a physician. So that means the physician has to tell you what you're doing and why, or other qualified healthcare professional. And we'll talk about that in a little bit. That would be someone with an advanced degree. This is going to be a face-to-face visit or encounter with one patient each 15 minutes. Therefore, if you spend 30 minutes with this patient, it's 97153 times 2, or you write the code twice, however the payer wants you to do it, every 15 minutes. Now, we're going to talk about documentation in a little bit, but that's very important. One, face-to-face, so they have to be physically there, and it's one patient, 15 minutes. 3 things that qualify for this code. If you don't have the documentation to support that, doesn't matter if it was done or not, it has to be documented. So let's look at the next code, 97154. This is different. It's still the same thing, the adaptive behavior treatment. However, this is for a group. That's key. That's what differentiates 97153 with 97154. Group adaptive behavior, again, everything's the same until you get to face-to-face, just like the previous code, with 2 or more patients, right? Each 15 minutes. So if you have 2 patients that you're working with together face-to-face, then you could use 97154. If you spent 30 minutes, it would be times 2. Then we move on to 97155. What differentiates those 2 codes? Again, it looks like the same and it reads the same until you get to which may include simulationist direction of the technician. Okay, so we're getting direction. This has to do with the adaptive behavior that's happened, but someone's over there telling them what to do. Face to face with one patient each 15 minutes. Then we move on. 97156, family adaptive behavior, which technically I would go ahead and underline family. I didn't because these are all but this is the header, family. And then it goes on, look in the brackets, with or without the patient present. So we could have the mother and father there, and the patient could be in the other room playing with a toy, or the patient could be there. Doesn't matter. So it doesn't have to be face-to-face with the patient. So face-to-face, though, with a family member or family members, with guardians or caregivers. So if you have a person that's a caregiver, say I'm taking care of an extended family member, then that's what I would be classified as, the caregiver. If you have legal guardianship over a niece or nephew, or then again, you would be the legal guardian and qualified for this code. And the patient doesn't have to be face-to-face. 97157, multi-family group. All right, so we have more family and more family, what do I want to say? Family members. So let's say we have two sets of parents, and they're getting educated on how to deal with this particular adaptive behavior. Okay, and then goes on to without the patient present. Now, 97156 is with or without the patient present. 97157 is without the patient present. So are they in the other room? Again, they could be in the other room. They could just not have been invited to the meeting. And this is a lot of times some type of instructional or training in a group setting. We all have a child or a family member that has the same particular situation, and there are diagnoses, and therefore we're educating you as a group. Face-to-face, so those members have to be face-to-face with multi-set of guardians or caregivers, meaning, you could have parents, or you could have aunt and uncles and parents together. So we're all going to chip in together and taking care of this particular child or an adult. It's not exclusive to age. 97158 is group. This is a group, not family members. Protocol modification is also in this. So adaptive behavior treatment with protocol modification. That means we're changing the care plan. And then it has to be face-to-face with multiple patients. So a group setting. Very good. And again, 15 minutes is always the increment for all of these. Now let's talk about, again, what the description is. We're going to unpack that a little more before we get into some of the other things that this person had asked. And I found this in Find a Code under that first code, and it's linked as the same with all of these codes in the range, more or less. So it's kind of a broad description of what active behavioral protocol is, in fact. I think this is the best way to explain it too, and kind of how I was trying to explain it. They're wanting to get successful achievement of treatment goals, right? We've identified what the problem is, what the patient needs help with, assistance with, education with, skill training. Okay, so think of it as, it could even be, it's not the same, but let's say it's more like OT. So if you go in for OT, but we're going to be working with behavioral health. This is an aspect of OT. So I need to teach you how to make a peanut butter and jelly sandwich, right? I need to show you how to set an alarm on your clock so you know when to get up every morning. So it's for maladapted or deficient behaviors, which again, kind of gives you, when you first read that inclination of, oh, this is a bad problem. These are bad behaviors. This means this person likes to hit people, or this person is aggressive. No, we're not talking about that. Maladapted meaning not in the social norms, and we don't mean that, everybody's got to wear red on Fridays. We're not talking about that. We're talking that personal space, that if you walk up to somebody and they say hello to you, it is not, I start to say it's protocol. It is acceptable or the norm to say, I'm fine, how are you? Or just, I'm fine. It's not just stare at them and wait to see if they'll go away, and deficient behaviors, I think of that as learning new skill sets, whether it's verbal skills, or it's being able to make that peanut butter and jelly sandwich, or it's how do you set the water on your shower to make sure you're not going to scald yourself or it's too cold, right? And it's based on previous assessments. That's important because there's another set of codes for the assessment. And my son had went through this assessment process, which takes a whole day ultimately, and they do all types of things, from making him walk up and down stairs to having him write things to watching him put puzzles together or describe a story or watch a short film and then turn around and tell you what it's about. All of these different things that they have to see what his skill set level is. Then once that's all done, you set up a set of achievement goals and then protocol. What's the protocol to teach someone how to interact on a meet and greet initial meeting? What would be good behavior? What would be mal behavior or bad behavior or not socially acceptable? So it's not socially acceptable for a person to walk up to you, stick out their hand and say, hello, how are you? Well, then to not shake their hand or to sit there and pick your nose. It's not acceptable, right? The treatment also includes ongoing assessment. So we have the protocol in place, we have a goal in place, and we need to assess them every week to see how they're doing, or reassess every time that they achieve this goal. Then what's the plan after that goal's made? As well as goals or treatment targets for continued appropriateness versus the need for adjustment. So if a person has autism and they have no desire to touch somebody else and they don't want to be touched, so they're not going to shake your hand. And so a person walks up to them and says, hello, how are you? And they stick out their hand, then that person needs to know how to react in that situation. It's not just stare at the person, just say, I don't shake hands. That's it. Or I'm fine, I don't shake hands, versus they stuck their hand out or they touched me. Again, once they learn that skill, then let's move on to the next skill set goal. Or we've got them saying, I'm fine, but they never acknowledge that person standing there with their hand sticking out. So now we're going to reassess. We're not going to talk about what's the first thing you say when someone says that to you, but now let's talk about how would you handle someone sticking their hand out? You don't want to shake hands, right? That makes you uncomfortable. Yes. Then what do we do? I'm going to tell them, I'm fine, thank you. I don't shake hands, or shaking hands, something like that. Multiple treatment sessions. Again, this could mean, we're going to be working on this for 3 times a week. We're going to work on this 3 times a month, maybe in a group setting, maybe in a single one-on-one setting, because that's the way the patient learns. The patient can't read, so we're going to watch videos and we're going to reenact to simulate what normal behavior would be. And then it goes down. Notice that I've bolded the treatment protocol and may or may not provide hands-on direction during the face-to-face administration of the protocols. So again, maybe they're going to watch a video. Maybe they're going to give them a book that allows them to read what is appropriate behavior, because maybe they just never learned it for whatever reason. So it could be, we're going to demonstrate, we're going to have two people walk into the room and show you what's normal behavior or acceptable behavior and how you react in turn, and then you're going to get to try it. It goes on also to say that they have target skills that they're going to work on, and it would be a specific behavioral deficit. Thus, again, that face-to-face initial encounter, what do? Such as, example, social, that would be social. Emotional, when you get upset, what do? Well, my son, when he gets upset, he will bang the door, right? If he's in a bad mood, he'll go to his room, but he'll open and close the door 4 or 5 times because that makes him feel better, I guess. And that's not a good way to emotionally take care of how you're feeling, because one, it's annoying to hear that for the family, but also he's big and strong and he could literally bring the door down if he wanted to, right? If he tried hard enough. And communication problems, again, that's pretty self-explanatory. The repetitiveness, harmful and or stereotypical behaviors that, some people will hit themselves, and he did that when he was younger. He would get frustrated and he would bang his hand on his head, and that you don't want someone doing that, or banging their head on the wall. And his service dog would stop him from, going up and trying to bump up against the wall when he was frustrated. His dog would get in between him and the wall and push him away from the wall and redirect him. So again, these are all things that would be addressed, and the patient would practice the targeted skill. What are we going to do? We're going to teach you other ways to get rid of that aggressive feeling or that frustration. Ask for help instead of trying to continue to do something on your own when somebody's in the other room that could assist you with opening the package of bread. The technician is going to administer the protocols daily in different settings. So we taught you how to say hello appropriately when somebody responds and not shake their hand to let them know that you're uncomfortable with that. And now we're going to go out to a public setting and practice that in a group. And then we're going to go to the grocery store and we're going to see how you do interacting with strangers. And then again, it says things like home, church, community park, store, playground, things like that. That technician during this whole time is going to collect, record, and even graph the data that the physician or that qualified person determines the treatment that requires adjustment. Okay, so that's going to directly be related to what we're going to talk about in a little bit regarding the documentation that's required. But note, if you use 97153 and you report each 15 minutes of the face-to-face service for one patient only, and code 97154, which is going to report each 15 minutes for 2 or more patients, but not more than 8. Okay, so that is important. 97154, you can have up to 8 patients, but not more than 8. Then it's going to change into a different code. When did all of this kind of we became more aware and they started making changes in the codes? It all happened in 2019. So they added a new area in the CPT for adaptive behavioral services, thus this question. And I suspect that's another reason why this question came in, is this person has the ability to use these codes, but really needs to be able to either educate the providers or their team or both on what do we need to use to be able to use to get these codes paid? What documentation do we need? How do we need to understand these codes? And I linked where this information comes from. It's in a CPT update. So it just goes on to say that it's in the medicine section, that the assessments are done with codes 97151, and 97152, which we talked about. There's going to be an assessment first, and then you go to the code range that we were talking about. The person asked about 97153 through 97158, and then there's within that guidelines and definitions in the CPT manual. I noted also that these treatment codes, they can be used by any physician or qualified healthcare professional, which is abbreviated QHP, by the way. So you might want to jot that down and add that to your knowledge bank, with an appropriate license or other credentials. So just because they are a QHP doesn't, in one area, doesn't mean they're qualified to be a part of this particular behavioral um, uh, collection of data and treatment. Okay, the majority of these services are directed by behavioral and analysts, and that's who my son went to. Behavioral analyst did the initial, and then the psychiatrist was there that specialized in people with brain injuries, people with autism, and people with epilepsy. So it was pretty unique that they focused in on that particular area. And this was all before he was set up to do an epilepsy study, a whole week in the hospital with this epilepsy study. They wanted all of this information first because that helps them map the deficits of the brain as well as what's not affected. Okay, so the behavioral analyst is an advanced degree professional, and when they mean advanced degree, we're looking at master's degree and doctorates, or licensed psychologist with competence in behavior analysis, meaning they've specialized in this. So you could have a licensed psychologist has a bachelor's degree, but they've gone on to get specialty training in this particular area. You know, then they would be able to prove that they could use these codes or be a part of using these codes. Note that it also stated there's only 30 states that require behavioral analysts to be licensed. So again, some of them, they don't even have to be licensed. When you're licensed, you are taking a board exam of some kind. Even if you're taking a specialty exam, our coding credentials, they're not licenses, they're certifications. But think of it just the same as when you get your driver's license. Your driver's license allows you to drive in the state that you were licensed in. So that means you took a test, both a skill test and a practical test. So you took a written test and a practical, go out and drive and show me. However, what they do in Texas may not be the same test that they give you in Missouri. Each state is different, and each state requires different things. So when we lived in Missouri, the children that got driver's tests in Missouri got to just go in at 15 and a half and set for the test. Before that, you had to be 16. When I did it, you had to be 16 before you took the written test or the driver's test. And you had to take the written, of course, before the driver's test. Now in Missouri, it's 15 or 15 and a half. I think it's 15, 15 and a half, something like that. You can go in and take the written test and get a permit, and then you can ride around with your parent, and then you turn 16, you can take the driver's portion of the test, or you can do them both at the same time at 16. In Texas, it's different. You're required to take like a 300-hour course before you're allowed to sit for the test or take the driver's test. And that is up until you're 18. Then you don't have to take that test, but you still have to take an online adult test of some kind. So I have a child in Texas that turned 18, and he was going to have to do that. Now you could take that online test, however many hours, supervised by your parent, or they did it at the school, right? So it's just like this. Every state's different, and they have the procedures and protocols in place that they want. You follow them, and that allows you to transfer to some states and not to others. So if my son had gotten his driver's license, my one that's 21 years old now, but when she got her driver's license in Missouri, then she just went to Texas and got a Texas driver's license, meaning she just turned her Missouri's in and they gave her a Texas. She didn't have to do anything else except for to prove who she was, and so on and so forth. Now let's look a little more in depth at the individual codes themselves. The codes are divided up in, first let's look at the service that's being provided and the codes. Now you're going to notice some additional codes here, and I'm going to highlight them, but actually I'm just going to tell you, you go out and research the T codes, all right? They're a little bit different, and that's kind of a whole extra study, but I'm giving them to you because it was given in the information that I had, and it is pertinent for you to know that. So if you are working face-to-face with a patient, remember \C is with, \S is without. So face-to-face with the patient, then you are going to be able to use 97153, 97155, or the T code of 0373T, and you can go look that up. And/or. Now, if you're direct treatment, that's what TX stands for, of the patient, PT is patient, in a group, then it's 97154 and 97158. Those are the two codes that allow you to do a group treatment. If it's family treatment and guidance, then it's going to be 97156 and 97157. So hopefully this shows you how the codes are divided up. All right, that's good to know. So when you see that though, and this is in the codes, it'll tell you, do not code with 97154 more than 8 patients. And we mentioned that previously on the slide. Do not report 97155 with 90785 through 90899. So you have to go look and see what those codes are. And then it gives you other codes that it's not applicable to code those together. You might think that you could, but ultimately it usually means that those things are bundled in and you just don't do them together. But we're not going to talk about that. We're not going to get distracted. Additional information that was given that I thought was pertinent, that when you have a physician, or remember the QHP, qualified healthcare provider, if they direct the technician that's actually sitting there doing the physical work, the treatment protocol without the patient present, okay, the service is considered as bundled with the above service codes that we just mentioned. Therefore, you're not going to report them separately. 97155 can be reported in 2 scenarios, and you notice face-to-face with patient. When the physician or QHP is delivering the treatment with the client one-on-one, or when the physician or QHP is directing the technician delivering the treatment, then you code 97153. And both the technician and the client / patient or parent or whatever is present. Okay. And you can make notes off this, however you need to make the notes. This is just a launching board. These are other highlights on what not to code together. And again, I'm not going to really go over those because they're actually in your manual, So when you look at 97156 or 97154, this is in there, right, under the code. But you need to pay attention because these are perfect testing questions to add those in there. This was a graph that was in this coding archives, coding update archives, CPT update archives. Gosh, I didn't say that right at all. And so I reproduced it and then just kind of made it my own. However, it's out there for you to go look at, and I just like my colors and stuff that I use. So let's just highlight. This is kind of a review, and some people learn better when it's all like in paragraph form, and some people learn really well with a table. So hopefully this will help you. If you're dealing with 97153, if that's the code you want to use, then you need to know that it's got to be by protocol, the protocol that was put in place. There can be number of technicians, 1. And what are you working on? Deficient adaptive behavior or maladaptive behavior, right? Then let's look at 97155. Well, that kind of meets everything. We're not worried about the protocol, but it's with protocol modification. So we can modify the protocol that was set in place to begin with. You have a face-to-face visit, and it has to have a QPH or QHP required to be on site. Just like if you work in a pharmacy and if the pharmacist says, hey, I need to go gas up my car and I'm going to come back, so I'm going to do that during my lunch hour, you guys can stay here or work. Okay, you can. However, you cannot give any prescriptions out. You got to shut the doors, right? Because if the pharmacist is not on duty or in the building, then you can't give medicine out, even if the medicine's already bagged up, ready to go with the price and everything on it. You're not allowed to do that. However, if the pharmacist says, hey, I need to go to the bathroom, they go to the bathroom and they go to the other side of the building, you can do it then because they're on site. Same thing here, on site, very pertinent. So notice that 0 or 1, meaning that you don't have to have a technician involved. And again, the same with the DAB and the maladaptive behavior. And it also includes destructive behaviors in that particular code. So you wouldn't use adjusting destructive or educating on destructive behaviors in 97153. Moving to 0373T, again, that's a baby code, so you can go look that up, and then the protocols for that are listed. All right. Ultimately, what that means is this is the code you use until it becomes a new code, and then they'll give it. Maybe it'll be 97159. I don't know. Protocol modification. How do they do that? I'm not going to read all of this for you, and you think, oh, gee, thanks. But again, it will be available to you in the slide deck, plus the link of where I abstracted this content is there. So adaptive behavior service protocol modifications involve what? We're going to make changes by the QHP to the procedures for implementing an adaptive behavior service. So we're going to make changes. This is what we thought we were going to do. Guess what? It's not working. The patient's not responding, or the patient's getting frustrated with this type of learning. So let's try something else. So let's change the protocol. Let's take out 2 of the 5 things that we were going to try to help the patient with, and just really buckle down and focus on the 3 things. So we're going to modify the protocol, what we set in place, and think of the protocol as the plan of care. Okay, and then this is what it includes. It's not limited to, and again, it's just changing the plan of care ultimately when you read A, B, C, and D. Documentation. We're getting ready to kind of wrap up documentation, and I see all of your questions coming there at the end, and I have a slide that will go over these questions, because thank you for doing that. I appreciate those. So the documentations. What are the documentation standards? 1, we want to make sure that we set up what is going to be our standard or protocol, and it really is helpful to have a compliance officer involved with this, because they usually are CDI specialists. So we have documentation requirements, and they're going to have accurate reflection of the session in and out times. because 15 minutes, everything's on 15-minute increments. So when you start with that patient at 1 o'clock in the afternoon and you end at 1:30, then you know you're going to be able to use that code times 2. That's 2 15-minute sessions. Provider and client information, meaning who was the technician involved, because you need to have it. We want to make sure that if this particular technician isn't licensed for destructive behavior, then they're not going to work with patient A because that's part of their protocol. Whereas, the other technician is licensed for all of them, adaptive behavior and social and all that stuff, and destructive, again, then we want to make sure that's the one that's signing off and is working with that patient, or ultimately you're not going to get reimbursed. Narrative summaries. What happened? What, give me an update. Give me a summary of how the visit went, how the patient's doing. Are they improving? Are they still struggling in one area, etc.? You want to be able to safeguard during audits. Again, you definitely don't want to have this particular provider that isn't licensed to do a specific skill with this particular patient. That's why provider and client information is very important. Review and understand the intent of the codes. Thus, those codes that we just went through, we understand they're 15-minute increments. We understand that some are face-to-face, some are not face-to-face. Sometimes the patient can be there and sometimes the patient doesn't have to be there, right? Do we have more in a group setting than 8? Then that code's not applicable, is it? Session notes clearly state what occurred during the session, a summary and stuff, and determined by the QHP not to modify protocol at that time, meaning that's all got to be documented if you decide not to do it. When you have a modification, it's with or without the technician present, and the services that are being done during a face-to-face session, the patient or caregivers are billable. So if you're modifying written protocols, we've written down these are our goals and how we're going to achieve them. That is an indirect service that is not reported separately. So you don't get to charge for setting up that protocol and that time of writing it. It's all bundled in with the 97155 for payment. All right, let's look at our questions. Let's see here. Our questions start. Nancy says, the truth is that I asked because I'm an auditor for a pay and we just started auditing these services, and I'm confused as to what to look for. Okay, I have got the resources, Nancy, at the end, those 2 articles. One is another presentation, a slide deck that's much more in depth and has a lot of billable information on it, and so that's going to be beneficial to you. Because that's how you're auditing. You're auditing off that. And it tells you what you need to know and what needs to be documented. And the most that you see is autism, and I'm not surprised because that probably is the number one thing. That next to epilepsy was really big in Austin because they had a huge neurological center there. Which my son's first neurologist down there in Austin was a specialist with autism. But my son's major problem was that he has epilepsy. So he was treating him for the epilepsy. And then he said, if it gets to where we're not managing it, he said, I'm going to send you to the epilepsy specialist. And so we did fine until he started having more and more seizures and the medicine wasn't working. And so we chose to look into surgery. So he transferred us to the epilepsy neurologist specialist. So he didn't deal with autism, although a lot of his patients did have autism. So again, I understand that being your specialty. Let's see. You have any suggestions for someone interested in psych coding? It's not easy to find information for psych coding. I know that wherever you're going to try to get that specialty credential, they may or may not have a study guide. So of course I would get that. but probably the best thing you could do is look at sites that are geared towards technicians and other QHPs documentation and their notes and transcription notes for psych. You'd be surprised if you can learn the verbiage, because again, the verbiage is not the same as it is for the medical aspect. Some words, they have same words, but they're completely different meanings. And so I would say that's where I would start, but find out where you want to get credentialed and then go from there, whichever credentialing agency you want to do it with. Let's see, now that COVID has come, not shaking hands is not awkward at all. You're right. And I think that may change completely. They say if you keep your hands behind your back, if you don't want to shake hands with people, or you put a purse. That's why you'll always notice the royal families, the women hold a purse in front of them. And that way they're not obligated to shake hands, especially if it's a purse that doesn't have a strap. On page 724, under the coding tips, when it says, if the healthcare professional personally performs the technician activities, does this mean if no protocol modification, the QHP should be 97153 with the appropriate modifier to indicate the level of the, I believe so, Nancy. I think you are correct. But I can also tell you another place to look for this is the payer's education. So find out who your payer is that you're going to be auditing for. Is it going to be a state Medicaid? Is it going to be Medicare? Because you do have Medicare patients that have autism. Or is it going to be like a Blue Cross Blue Shield or United Healthcare Humana or something? What I would do is I would take that first code, the 153, 97153, and then type in your search bar, Humana, and then 97153. That's how I would search it. But yes, I believe that is correct, Nancy. Nancy's the one that asked this question, so kudos to Nancy. All right, guys, you're welcome. Darman said thank you. All right, and Nancy, again, anytime, because you're in the club, if you're still searching or you need help on something specific, you just pop that in there, and I or someone else is going to be in there looking. I know Jennifer is definitely going to be able to help you more with billing, the billing aspect than I am, just because she's more versed in billing. However, most of those things that have to do with particular payers, and usually whatever Medicare does, or even Medicaid's state level, of course, you'll find that it's repetitious. Yeah. But this particular question is exactly why we do these videos, these club videos. And there's the references there. Again, there was only 2, but they were good, really, really good. And I accessed the one CPT archive via Find a Code. Well, because we pay extra for that. But again, if you have Find a Code, it doesn't cost much more to have that. It's CPT Assistant or CPT Update. I can't remember which one it was, and it'll tell you the month and the page numbers that you need to look at. Advantages of the CCO Club. I appreciate everybody that came tonight, and hopefully this was beneficial to you. If you have a question that is even, honestly, this is a little outside of the box of the norm that we usually deal with, but that's because there's just not enough education out there for it. And there's always room for improvement. So as Nancy finds more information, she'll sell, because she's doing audits for that, she'll share that on the club, and then again, you'll be able to reference this question and say, oh, look what else she found, as she did her own study. But ultimately, hopefully, we were able to give some insight of what we were able to research and find. Not an expert, but it's all about networking, right? And research. And sometimes it is just not knowing the right term. You might not get anything by putting in your search bar adaptive behavioral protocols, Humana. However, if you put the code in, and you're going to get it, because they will have done education to their providers and clinicians for that very code. And as always, find out who the main payer is and tap into them specifically, their websites. It's no fun to call them, but usually they respond usually within 24 hours if you send in a question, say, hey, I need some links as to education regarding audits that I'm doing for these codes. All right, thanks. Great question, Nancy. I appreciate it. Thank you for sharing that. And we are just right there on the hour. If we don't have any questions, then we'll wrap up. Thank you guys for I'm just going to look right here at the names of the people and see if my friend Claire was able to show. I don't know if she was here or not able to. She's getting ready to do some traveling. But know that it doesn't matter if you're not watching live streaming, because you just go into the CCO Club, this video's there, and we'll bundle this in with a lot of other behavioral health and psych presentations that we do, so you don't just get one CEU at a time. You can get 5 CEUs and really break down some meaty discussions, and hopefully it's not boring or dull to get applicable.
I've got one question here for you.
Okay.
Eileen over in YouTube asks, I have a question about E&M 99415. The patient had BCBS but was rejected because he has Medicaid. Can you help? I'm a coder. I don't know if that's related.
Okay, let me just look real quick here, because I have find code up. So let's just put it here. And thank the good Lord above, I am in a place where I have good internet.
99415.
99415. Okay, let's see what we got real quick. Prolonged services, clinical staff services, this service beyond the typical service time. Okay, prolonged. During an E&M, office or outpatient setting, direct patient contact with physician services. And what is the question again about the code?
Patient had BCBS and was rejected because he has Medicaid.
Oh, okay. Let me just look. This is what I do. I look at the articles first to see. Ooh, look at that. Look how many we got. Let's see. Reviews. Prolonged services. There is certain payers that don't pay for it, by the way.
It's like a Medicaid keyword. Is that what you'd be looking for?
Yep. So that wasn't beneficial. So let's look here. Frequently evaluation may value prolonged service October. I'm just looking here to see if they're
that bigger for everybody.
Nope. Yeah, let's see. Sometimes they'll coding tip. Duration. This I'm just looking directly for Medicaid to see if there's any billing tip. And as well as determined by each individual insurer and third party for reimbursement. Okay, well, I see nothing specifically, but I can tell you, if your patient has has another insurance, Blue Cross Blue Shield, any state or federal payer is not going to pay before Blue Cross Blue Shield. They're just not, because they always pay last. That's standard. But another thing that they will do is that Blue Cross or your other payer, Medicare or Medicaid, will look at that particular code and they say, okay, we pay out 99415, we pay out $100. I'm just picking out something. We pay $100, standard flat fee. Okay, so then Blue Cross Blue Shield is the secondary insurance, and they look at it and they say, you know what? We pay out $105. And you already got $100 from the other payer, so we're not going to pay you $5. You just have to eat it. they can do that. Now, if you have a scenario where a code, let's say this was a $500 bill, and the federal or the state payer says, we pay out 300, and then, but that's it. That's all we allow for that particular code. And then Blue Cross Blue Shield comes out and says, well, we pay out 400, but we don't pay 5. So we know what the other ones paid out. They pay out 300. So we're going to pay out 100. And so you don't get 500, but you only get 100 for your $500 bill. That's the way it works. Does that answer the question? And if they have 2 insurances, you can't recoup that money. You can't ask the patient for it. Unless it's something that's not covered by the federal or state insurance. And then if it's not, then the other insurance has to pay. Or you need, and if they say, no, well, you don't pay for that either. So in prolonged services, again, is, that's tack on time. You got to really prove why you had prolonged service. Why did it take you longer than it normally does? So really good documentation. So once you prove that, then they would say, we have them sign an ABM because we're not going to pay for it. But you can't make a Medicare, Medicaid patient sign an ABM for a service. So chances are you're going to eat that. They can choose not to pay. Now, if it was another code that's not prolonged services, meaning extra work was done outside of the norm for whatever reason, because it was a complex medication or blah blah blah, they're not going to do that. They'll pay you. But prolonged services, no, you should have been able to do it in the time that was allotted. We don't pay for complications. So you could eat that.
Groovy. I think we're good.
All right. Hey, we did it on the hour plus 1 minute.
One question: can you override it?
You can try, but you can't make the patient pay it. And you can't bill Blue Cross Blue Shield before you bill the state or federal insurance. So let's say, they have the government insurance of whatever type, and they say, we don't pay this. Okay, you don't pay it. So you take that denial letter that says we don't pay it, and you send it to Blue Cross Blue Shield and say, they don't pay, so we're billing you as the secondary insurance. And then they will or will not. But honestly, if you want to get it paid, the best thing you can do is have amazing documentation. They don't just pay that because your provider is slow at what they do. You have to explain why it took longer. And so that's really good documentation from your provider. And if you don't get that, again, you're out. You're not going to get paid. And so that's definitely more education you need to give to providers, especially if this is just a one-off, it happens once in a while. But if this is happening routinely, there's a problem. And you need to address what the problem is. Why is this taking longer? If it is, maybe we're using the wrong codes. The initial code. Maybe you're actually doing another procedure or service versus what we're billing. So if this is supposed to take 15 minutes and it's routinely taking you 20 or 30, why? Is it because all of your patients are, brittle diabetics and you have to do extra procedures? Then you code all that, document it and everything. You have to have a lot of supporting, and you send that in with the denials and things. But otherwise, maybe you need to go back and have compliance look at it and audit it and say, why is it taking you longer and nobody else? Maybe it's because you're a specialty provider and it just takes you more time. You have sicker patients to deal with than your average. Then again, reach out to them. But that's the way it works. Yes, you can fight it.
Groovy. Okay, that's it.
Thank you.
Thank you, everybody.
Let me go back to my, get rid of that so you can see our screen. Thanks. Don't forget, cco.us. I like doing this /club.
Good night, everybody.
Bye, guys.